So, good evening, everybody. We are live now. We can proceed.
Good evening, everybody. It gives me great pleasure to welcome all of you to attend the first web education series of the Arthroscopy Committee of Indian Orthopedic Association. This being the COVID times, it has certain advantages, and this is one of it. You can spend the evening imparting knowledge and learning more and getting in touch with other people as we say so. I would invite our esteemed president, Dr. B. Shivashankar, to say a few words, followed by Dr. Navin Thakkar, our esteemed honorary secretary. Dr. Shivashankar, please.
Good evening, everybody. Thank you, Dr. Kanchan Bhattacharya, for bringing all together on this platform under arthroscopy in the IOA subcommittee of Arthroscopy Academy on this ACL injuries topic. This is the beginning of a series of webinars. Thank you for the efforts you and Rajiv have taken along with the president of Indian Orthopedic Arthroscopy Society, Dr. IPS Oberoi, along with Secretary Dr. Sundarajan. Friends, I am getting messages from many of our members whether we should carry on these webinars in this time of COVID, when so many of our members and their family members are in deep trouble. Yes, our sympathies and best wishes for those who are admitted and taking treatment. We have lost so many of our members in the recent past in the second wave. IOA stands behind the family of all its members. But friends, we cannot stop. The things has to go. We have to move on. So, as Dr. Kanchan Bhattacharya rightly said, this COVID also has given us opportunity and free time to refresh our knowledge on various subjects. And in this direction, these are some of the webinars which are going on. I once again welcome all of you for today's webinar, and I call upon our IOA Honorary Secretary, Dr. Navin Thakkar, to say a few words before the arthroscopy people will take over from us.
Thank you, Dr. Sivasankar and the team of Arthroscopy. We welcome you all for arranging such a good program in a short time period. So I will not take much time, and I would like to ask Dr. Kanchan Bhattacharya to proceed for academic activity so that we get maximum time for the academic activity. Thank you, sir.
Thank you. So may we start with Dr. Altaf Kahusa, who's going to tell us about how much anatomical ACL reconstruction using an anteromedial portal. Dr. Kahusa.
Thank you, sir. Thank you, Chairman, sir. President IOA, Shivashankar, sir, Dr. Naveen, sir, and other faculty, and the people from ACL. Good evening to everybody. So, I've chosen this topic. I'll be presenting a brief study about how much anatomical ACL reconstruction using hamstring grafts through accessory anterometal portals. I'm working as a professor in Government Medical College, Srinagar. So briefly speaking about the native anatomical position. So the motive behind ACL reconstruction is to have a functional restoration of ACL to its native dimensions, collision orientation, and insertion sites. This is the view which we usually see during the arthroscopy at the 90-degree flexion. So this gives an idea of this anatomic location of anterior cruciate ligament. And brief anatomy, the position of ACL in the extension as well as flexion. So why medial portals and accessory medial portals? We all know that anteromedial portals helped us in giving an anatomical reconstruction, but why these accessory ones also? Because we feel that weaving from the same side as well as having instruments on the same side gives a direct look on the medial wall of the lateral femoral condyle. So this allows us direct visualization of the wall as well as control of the obliquity of the femoral tunnel, thus better length of the tunnel. So how do we define the native femoral and tibial location of ACL? So we could simply take the remnant of the ACL fibers using thermal probe, or if we use this bifurcate and resident ridge and bifurcate ridge, the position is halfway between high and low position and just deep to the bifurcate ridge. Some people use the rulers also. So add 50% of the site in shallow deep direction and 6 millimeters above the articular cartilage. We could use this method, but we are not routinely using this grid method. But this helps in the accurate location of the anatomical site. So the surgical technique. So we do routine surgical technique. This is the one which we use, the portal superior one. So this helps us in weaving. So this looks on top of the instruments. So after clearing of these, then this is the second portal. Here you got to direct it accordingly. That identifying the said, the advantage of accessory middle portal is that you are directly looking at the wall and you are looking on top of your instruments. Hence, you have a better visual control of the anatomical side. Then this is the tibial side preparation, the usual method. Then tibial reaming. And finally, the ACL on the endo button. So as we know, this is how it looks through the anterolateral portal. But you have a direct look on the femoral side as well as the broader view of through the anteromedial portal view. So we actually wanted to know, with these delicate measurements and positions, we thought that it would be interesting to know how accurately is actually ACL reconstructed to its native anatomy, and clinical implications of ACL if it is not reconstructed anatomically. What happens if it is not done anatomically? So we have a group of 40 patients, 34 males, 6 females, with an age group of 18 to 45. Anatomical single bundle reconstruction was done using hamstring grafts, and we used the medial and accessory medial portals. And the people were followed for a period of 2 years since 2015. How we assessed it, we saw both clinically as well as objectively. Objectively, we used MRI at 1 year post-op. So how would we know the actual location of this anterior cruciate ligament, newly reconstructed one? So we chose these parameters, the location of the femoral attachment site, the tibial attachment site, and then assessment of the femoral tunnel, the femoral graft angle, inclinational angle, and the tunnel diameters. So if we go by this, if this is to find the location of the femoral entry, it has to be the posterior cortical line and the scar of the physeal scar in the sagittal image. This is the anatomical location. Then assessment of the graft. So one of the parameters is looking at this graft inclination angle. This is the angle between the graft and the tibial horizontal line. So the mean inclination angle in our grafts was 54 degrees, the anatomical range being 43 to 57. So 95% patients had the inclination angle in anatomical range. So this is one of the parameters. Then assessment of the graft in coronal position. So this is graft inclination angle, the angle between the tangent line of the tibia and the line through the graft. So the normal angle The anatomical range should be less than, the anatomical angle is less than 75. So ours was 70.5, again in anatomical position. Then femoral tunnel assessment. So this is done with a femoral graft angle. It's the angle between the line that best defines the graft and the tibial plateau line. The mean was this 50 degrees, and the range was this, and the anatomic one means 53 degrees, while as in transtibial, it used to be more vertical at 75, around 75. Then the location of the tibial tunnel, whether we have been in anatomical position from the tibial side. On sagittal image, the center of the tibial tunnel was measured as the percentage from the broadest diameter of the proximal tibia. So the normal is it should be around 40% of the normal size. So in maximum patients, 37 patients, it was in the anatomical range, 39 to 46. So 95% patients had tibial location in the anatomical range. Then if you look in the coronal plane, this again has to be at the 50%. So our mean was 52.5, 52.1%. Then this is very important, relationship with the Blumen's line. Normal good anatomical graft should be posterior and parallel to the Blumen's line. So in our 92.5% patients, it was in the anatomical range, but we had a couple of patients who had it anterior to this line, not in anatomical position, while in one, it was grossly posterior and divergent. So again, this is same showing how much anatomical it was. So we had 92.5% that was in the anatomical range. Then assessing the tunnel diameters, though MRI is not good for tunnel diameters as CT would be more informative. So there was a mean increase in the diameter of 38.72% and 35.1% respectively in the sagittal and coronal planes. The mean increase in the tunnel diameters was 37.26%. Again, if we saw that we had this initial 8 millimeter tibial tunnel that gone to 11, and in the coronal one, it had gone to 10.74. Similarly, there was increase in the femoral side also. So again, looking at the femoral tunnel clock position on axial MRI cuts. So in 25 right knees, so it was at 10 o'clock, and it was 10:30 o'clock in 12 patients. So this again showed that, like we previously used to use this clock position clinically. So it somehow goes again to repeat the same ideas, like if you had to put your graph around 10:30 or 10 for the anatomical position. Similarly, for left knees, 15 left knees had it at 1 o'clock, and others had at 2 o'clock in 3 patients. We had some complications identified on the MRI. So there was graft impingement in 2, cystic degeneration in 1, and we had 1 cyclops lesion. This is tunnel enlargement. You have synovial fluid and associated degeneration. So if it was in non-anatomical position, you had impingement in the anteriorly placed tibial tunnel. This happened in 2 patients. And there was a case of cystic degeneration in the ACL and 1 cyclops lesion. These are localized type of anterior arthrofibrosis, usually happens in 1 to 10%. And however, they are usually asymptomatic. So coming to my final actual question was, how anatomical was the reconstruction? So 95% cases we were accurate, and only in case of the tibial tunnel we had some issues. There were only 92.5% was in the exact anatomical position. So what implication did it have? If it was anatomical, so we had excellent result in 28%, 28 patients, good in 8, and fair in 4. And the clinical implication of non-anatomic reconstruction. 2 patients with anterior tibial canal presented with impingement and anterior knee pain, and 1 patient with gross posterior tunnel exhibited grade 2 Lachman's test, but a negative pivot shift. So the conclusion is using anteromedial portals and accessory portals can yield accurate anatomy of the reconstruction. Use of ruler and grid may further increase the accuracy. We don't have any comparative grip where we could compare the anterolateral ones, how accurate actually objectively the anterolateral ones are as compared to these anteromedial portals. Thank you very much. Thank you for your attention, sir.
So if there are any questions.
Altaf has to leave for iftar. I think we can have questions with him right now. Yeah.
We can have it now, sir. I can still stay with you till 7, sir, 7:15.
Dr. Nishit sir wants to ask. Unmute, sir. Please unmute yourself.
Before Nishit asks Altaf the question, I will ask him. So you are in Srinagar and your presentation was crystal clear without any interruptions. How is
Right,
the network there at present? That's my
yes, sir. Yeah. After Geo, we had it, I think 1 year back, Geo fiber was installed. So after that, it's now clear.
Okay, good.
Okay. Yes. Otherwise, we used to have lots and lots of issues.
I know. Yes, Nishit.
Altaf, excellent. 95% results are very good, very good. There are 2 things I wanted to ask you. That you said that there is the impingement on MRI.
Yeah.
Okay.
Impingement. Impingement on
this was you took the MRI because the patient had impingement, or
no, like... actually no. What I'm telling you, this was my study. I wanted to know. This was my question. That if we are trying to do things anatomically, but in reality, how much is actually anatomical? That's what I wanted to know. So on that, once we assess different angles, different in coronal and these planes, and this was a finding. We found that the one which had anterior had impingement. It was MRI documented impingement.
No, but clinically
didn't have any symptoms.
Okay.
This was because this was an objective assessment. I wanted to really know, because many times the arthroscopic anatomy and an MRI anatomy, and then once actually going through the arthroscopy, this actually it's kind of person to person basis, in the sense that what you will take the exact anatomical point and what others would take. So I wanted to actually know what we are usually taking as anatomical is really anatomical.
Right.
That was my question.
And secondly, what was that, everybody of us who are doing ACL had a blowout problem, tunnel blowout, sometimes. So if you see this patient after, let's say, 3 months, 4 months, 5 months, they do not have any problems remaining, most of the time. My observation, I might be wrong. So if you have blowout, it is non-anatomical, right?
Yeah.
So why then they have the full function?
The only importance is that, sir, if there's an anatomical range, like I showed, you have a range. And it depends upon actually where is the attachment side, not on the tunnel only. So it's attachment one. Attachment could be still correct.
No, but this tunnel will be always lower than what we have expected to be, right? Because it is a blowout. Of course, not a big one, but so I was just debating in mind that why they do not have any problems.
Actually, sir, this
afterwards.
is to be based on evidence. Actually, how many patients actually don't have any problems? Maybe a couple of patients, if we have seen that they are not having problems, doesn't mean that overall all the people who have had blowout would function normally.
Right. Other faculty?
Dear Altaf, it's a very good presentation. I would like to know what kind of tibial fixation are you using for all the 40 cases?
We used to use this. We used interference screw, but of late, for last few years, I am using tibial attachment sparing grafts. So we use a staple for them. We use this endo button and a staple on the tibial side.
Because the
So
tunnel,
your graft is always long.
Yeah, yeah.
because I saw
Because
that.
we take both the tendons. Because I of late for I think for last 2-3 years I am using tibial. I have another study. Dr. Rajiv also knows that he knows that I presented those, like what happens if you have anatomically this tibial attachment sparing tendons. Like we keep the tibial attachment preserved and use the tendons for reconstruction. Then I did their MRIs at 8 weeks to see if they really were viable. And it was it was a wonderful study. And I saw most of the tendons out of, I think 29 out of 30 tendons were still viable at 8 weeks even. So my intention was to find in that case that if you did biological one, the one which had a tendon sparing attachment was spared, does it provide viability? And looking at the MRIs at 8 weeks, it was really, really very promising. So the idea was if we have a viable tendon to begin with at 8 weeks, this will allow an accelerated rehabilitation, and you wouldn't have any re-ruptures early. So in that case, I wanted to answer you that in that case, why I use staples? Because I didn't want to strangulate the tendon with interference sinews. So that's why I use staples on the tibial side. And it doesn't give any interference with the MRI.
Nice presentation,
There's a
Dr.
spike staple, or is it a simple
Yeah,
staple?
yeah, spikes.
Okay, and titanium.
Yeah, yes, titanium, so that it doesn't have any influence with the MRI system.
Right.
The only thing with this inclination measurement is that you have lots of inter-observer variation also. If you see the article by Pimbrzeski et al. From Australia, so they did it with 3 different observers. So a single observer did the inclination measurement, or you did it with 2 or 3 persons like that?
Because the radiologist is the measurement, sir.
Oh.
So we don't have any issues with that.
So it was done by radiologist?
Yeah, yes. Like in this study as well as the other studies, I kept them blinded for this tendon intensity, because I would say if I did it myself, I would be biased towards it as, yeah. So once we give them both. I have another study, the third study, at which what we did at 1 year, we compared the results of the attached ones with detached ones. So in those, we didn't tell the radiologist which one are from the tendon sparing, attachment sparing ones and which one are from the detached ones. So once he gave the result, then we analyzed them.
All right. Sir, we can go with our next talk. Kanchan, sir?
Yes.
Thank you, sir.
Thank you, Dr. Altaf. Thank you.
Thank you, sir. Thank you.
Right. Thank you, Altaf, for your wonderful presentation. So I'll go forward with something which is really very basic. And over the years, I find that this is assumed a different kind of importance nowadays because of the expectation of the patients and because of the quality and the class of patients that we see nowadays, as opposed to what Nishit and I did during an early phase of our career. Now, we realize that ACL reconstruction is a very common surgery. And how do we know it's common surgery? Because the insurance payment is structured at very, very less. If it's a largely operated, if it's a surgery which is common, they don't pay you much. If it's something that you do very rarely, like excision of a toenail, you get a lot of money. So this is how you know that this is a very common surgery. However, even though it's very common, and there is no consensus about what the best graft is, just to be a devil's advocate, there's still no consensus about where the femoral attachment is. I'm sorry to say that, Altaf, but we still don't know exactly which is the best part. Yet, whenever we do a surgery, the best part and the most important part of the surgery is to replace the ACL graft with something that will be very close to the one that God gave us. The options are, as we know, autograft, allograft, and synthetic. The ones that we commonly use are patellar bone, tendon bone, the one that we learned with in our generation, followed by the hamstring, either the semi-T alone or semi-T and gracilis. Then the quadriceps tendon, and the newest kid on the block is the peroneus longus. The allograft, which is largely not open to us until very recently, and the synthetic one that was only of scientific importance to us forever, even today. Whenever we do an ACL reconstruction, the thing that comes to our mind is it going to fail or how is it going to fail? And is it going to fail because of the graft that I've used, or is going to fail because I did it poorly? And the most significant negative outcome of an ACL reconstruction is a graft rupture. However, several prospective and retrospective studies comparing different grafts, be they BTB, be they hamstring, or quadriceps tendon, have found that the rupture rates to be pretty much similar regardless of what graft you have used. However, and this should not be omitted from our knowledge, that a very large number of close to 46,000 ACL reconstructions were retrospectively studied in Scandinavian register in 2014. They found that the higher risk for rupture of hamstring autograft recipients compared to BTB. And remember, in Scandinavia, as opposed to North America, hamstring grafts are used more commonly than the BTB grafts are. Today's challenge is that we have a huge cohort studies with grafts like quadriceps tendon, BTB, peroneus longus, allografts, and also synthetic grafts. And some of our patients have already read them or have read about them, or some of them have been advised by doctors to go to have one graft or the other, and with good reasons. These patients are generally younger nowadays. They have increased activity, and you have options of an allograft, and they're extremely informed patients, and most of them have unreasonable expectations. There are a host of factors that decide how the ACL is going to behave. And there's only one factor that we can decide, and that is the graft. We can decide what graft to use, and that is the only thing that we have in terms of the risk factors. When you have compared the autografts to the allograft, the only reason I use this is because allograft is now available in our country, and I have a couple of friends who've used allografts for primary surgery as well, and the prices are not as prohibitive as they used to be. But for me, this is just for academic interest. In literature, you have similar stability in long-term and mid-term studies. Sun et al. Was the only one who did a prospective head-to-head studies of BTB act autografts with allografts with about 80 odd patients in each one of them. At the end of 5.5 years, in terms of stability, the results were kind of similar. However, there's one study by Gorchevsky, and a lot of people who do not like allograft always refer to this, in which this, at the end of 6 years, the 45% failure of the BPTV allograft as opposed to the autograft at the same time. They have, however, attributed it to the treatment of the autograft for its preservation and sterility. That was probably the cause, and because this is the only one that has got such bad results. However, one of the reasons why we should not opt towards allograft is because it's expensive. It's not so easy to acquire, not demonstrably better than the autograft that we use. There's always an apprehension for rupture because of several studies that have happened and for disease transmission, and we are not quite sure what the regulations are today and what they're going to be tomorrow. The synthetic grafts have been there for a long, long time. A lot of them have gone off the market because of the poor results that have happened. The newer ones will be probably better. This come of scaffolds and probably will have less reactions. And there are some athletes who want to go back to preseason time and have a temporarily synthetic graft which is in place. And also do not forget the synthetic augments, like the internal brace, which will probably be part of that synthetic graft issues that we use. The other option that we have is, we don't normally consider this, but this is something that definitely needs to be considered, is living donor allograft. In children below 16 years, it can be used in primary as well as in revision. Parents are good source and donors, and recipients should always be suitably screened. Again, there may be regulations that we do not know, but Nishit Shah and Leonard Ponraj have been doing it for a long, long time. And they would be better placed to tell us about what regulations we should be following. And they have had good results, I know for a fact. Of the grafts that we commonly use, hamstring is the one that's most commonly used in our country, though we, Nishit and I, we learned it in BTB and we all moved over to hamstring. Hamstring is easy to harvest. There are several options for making it a little long. We can use 1 or 2. We can make it thicker by making 3-fold or 6-fold or 5-fold. And there are several fixation options. We can use it in the you can use it in the tunnel. We can use it in the mouth. We can use it just like Altaf has mentioned. And the industry loves it. Because of fixation modularity, it can sell a whole host of fixation implants to us. And this is actually a boon to the surgeons because that's how we learn more and more about how things can be done. Some of them are to our advantage. And most studies rate the efficacy is equal to that of bone, patellar bone, tendon, which for a long, long time has been considered as gold standard. It's a dependable, predictable graft. Looks very robust, but you have to be careful. Harvesting is not very easy. It may be a technical more demanding than a BTB. You have to clean your bed and the tunnel a lot more assiduously than you would in a hamstring, which is pulled in like a rope. The workhorse of fixation is of the implant is the interference screw, most commonly a titanium interference screw. Of course, you can always use the bioabsorbable ones. But today, just to make everybody happy and the industry not to be put behind, have come up with both rigid loops and adjustable loops, primarily for femoral fixation. And there's a whole host of fixation devices for the tibia. The cons are the possible donor side morbidity, the anterior knee pain, the kneeling pain, and maybe the scar. I still follow a single scar, which is about 2 inches long, just a tad medial to the midline. But you can also do it like the one that's done here, two small incisions. I have somehow not tried that, not very good at it. I'm scared of doing it. But a lot of people, a lot of my friends are very good at doing it. Quadriceps tendon is something very strange. It's a very poor cousin, and for no fault of its own, it was first described by Marshall in 1979. Actually, it was used earlier too, but for ACL, Marshall used it. But somehow it just fell off the radar. There were not that many proponents for it. When you look at the literature, you'll find that most of the literature of quadriceps tendon date back to only about 10 years. But if you look at the cadaveric picture, it's a strong, robust graft, and it's more than a centimeter thick, just proximal to the patellar attachment. And you can take even half of it and it'll still be about 7 to 8 millimeter thick. So you can get a graft of anything from 7 to 11 millimeter at ease. Even without the bone block, you can get 70, 75 millimeter length at ease. And comparative to semitendinous BPDB graft, the results are comparable. Again, it has huge fixation options and hence the industry blessings. It is, I think, clearly the graft for the future. It's so easy to harvest, and you can do it with a very small incision, and it does not affect the strength of the quadriceps, as has been shown by literature. You can make it two-tailed for a double bundle as well if you want to, and there's minimal morbidity. And Rajiv has shown us another way of doing superficial quadriceps tendon graft, which is thin and narrow and long. It can be two-fold, three-fold, or four-fold. And I've used it a couple of occasions. But only thing, you have to be young and a little strong in getting it. But it's a wonderful way of getting this graft. The newest kid on the block, of course, is the Peronius longa, started in Southeast Asia, but we use it a lot. We use quite a lot, more in revision and multi-ligamental situations and less in primary situations. But there are people who are using primary situations as well. The advantages are that it can be easily harvested. It has a large diameter, and it can be used as three-fold or four-fold. It, it can double the PL graft is actually stronger than a four-fold hamstring graft. The disadvantages are that it's a recent addition to an autograft, and we are not quite sure how it's going to behave in the long term. And the possible weakness of external of ankle eversion and plantar flexion is the first way. And Rajiv tells me that someone in Bangladesh has already shown with the cadaveric studies in small patients, the harvesting might damage the lateral popliteal nerve as well. There's always a geographical influence to your to kind of persuading you what graft to use. And when you look at this busy graph and to the pie crust, in Canada you'll find that all the blues that you see are bone, patellar bone, and the green is hamstring. So you'll find in Canada in 2010 there was a preponderance of say 59% of BTB. In Norway, 60% hamstring. And in the US, even in 2010, Moon shows that there's 44% of hamstring, 42% of BTB, and 14% of others. And then in 2017, again, you find that in the US, it's again 45% hamstring and 14. But in this, a total of close to 60% was hamstring. But more people were fond of using both CMT and gracilis and less of CMT alone. And then BTB was there, and about 83% autograft and 17% allograft, which is by far the highest in anywhere in the world. And then later, in about 2018, the graph is changed. Another survey showed that that even the American surgeons are leading more towards hamstring. So you have about, in the male, you have about 81% of hamstring, and in the female, about 91% of hamstring. More hamstrings being used nowadays in the United States of America. But this is just one survey, maybe a little skewed also. So you don't really follow it blindly, but it is something, because until very recently, until like the early 2005 or 2006, USA and Canada is about 85% BTB, and that took into account all comers. When you look at the comparison between BTB, hamstring, or quadriceps tendon, most of the long-term studies do not show a big difference in outcome between one and the other. The failure rate, or the failure rate, or the revision rate, or the stiffness rate, the amount of Lockman's positivity or puberty positivity, they are kind of comparable. There are some which are a little different. I'll come to that. The CQT and BQT, that is the central quadriceps, and the bone quadriceps tendon, which is reported a little less in head-to-head studies. There are only 3 studies of bone quadriceps tendon and BTB comparison studies, and they show kind of similar results to both of them. But this is where the big volume surgeons should pay attention. When you look at, this is a study from Moon Group, from young student athletes from high schools and colleges from age group 14 to 22, for 92% of the followers for 6 years, and you find that of those, hamstring was used in 64%, BTB 36%. And what are the results? The results are the incidence of ACL graft revision at the end of 6 years was 2.1%, 1 times higher with the hamstring autograft compared with the BTB autograft. And a kind of similar study is again from Philadelphia Rothman Institute, and this was again a large number, 256 female athletes, about the same age group, 14 to 22, again followed for a large number of years. And what were the results? The re-tear rate occurred 6.9% in BTB, 13.6% hamstring. That is, again, hamstring is about 2.1 times higher than BTB, and this is really very important. So when we decide on what graft we use, we look at the outcomes, and outcomes of almost all the autografts that we use are pretty much the same in terms of muscle strength. When you use the quadriceps tendon, the patellar bone tendon, none of the studies have shown weakness of quadriceps long-term study. However, few studies, in fact, 3 of very large studies have shown persistent hamstring weakness in hamstring graft. And that is why some people have suggested that you stay away from hamstrings when you are doing it in skiers or gymnasts who use their hamstrings a lot more. The function is about the same with both of them. The infection rate is about the same of them. Cohen has suggested the 92% satisfaction with graft choice, regardless of how you do it. And in terms of return to sports, 65% return to pre-injury level, and that's what Govic said in 2006, regardless of what graft you use. To summarize, you have to weigh all your options that are available. Stick to the one that you are most comfortable with, and always have backup plan, especially for fixation or if something happens to your graft in the middle of the surgery. If you're a high volume surgeon, you might want to go horses for courses, and that's the reason I say this is because unless you're comfortable using any graft that I've mentioned, it's not a good idea to suddenly change for one patient at a time. The at-risk subjects are adolescents, female athletes, big guys whose sporting activities involve a lot of pivoting, and something that I've not mentioned, that patients who have hypermobile joints. Always explain the advantages and possible complications to the patients who come to you. And an appropriate informed consent is mandatory, especially in today's context. Thank you very much.
Sir.
Yes.
So what is your preferred graft for ACL reconstruction? Because you operate lots of sports person also in
Yeah. So
Yeah. So
mine is, I'm still sharing screen, am I?
no, sir. You're not sharing.
Okay. Okay. So my preferred is, for the vast majority, is hamstring. For female athletes, almost always BTB. For big footballers, BTB. For revisions, mostly BTB.
Welcome, IPS Oberoi, sir, President of Indian Arthroscopy Society. Welcome, sir.
Thank you, Rajiv. Good evening. Thank you very much. So can I
Any
share
more
the screen,
questions?
Rajiv?
Yeah. Nisit, sir?
Okay.
Yeah. Mine is still, as Kanchana said, BTB, and I usually now with the small 2 incisions, BTB, harvest. And I think that is a good technique. I will like to present it sometime. And hamstring, yes. And for revision, always BTB and quadriceps. Few times I take both the things simultaneously, bone vertebral bone and quadriceps. And I have not seen a lot of problems with these patients because I am very careful about bone grafting the defect in the patella or all the time after the once I harvest the graft. Peroneus longus, I have still doubts in my mind, especially with the very fatty patients and athletic type of patients, and because our population sits on the ground all the time. I keep my fingers crossed for Peroneus longus graft. Because I think that the opposite knee has worked very well with me for years together. So Peroneus longus is my last choice.
I think we can proceed with
Go to the next talk, sir.
presentation.
Kanchan, sir.
Yeah.
Yeah, so IPS, it's your floor now. Why you use
Yes.
hamstrings?
Thank you, Kanchan, Dada. Thank you, Rajiv. Greetings and good evening, Dr. Shiv Shankar. I think that's a very great initiative which you have started. And thank you, Altaf, for joining in, and Nishit Bhai for giving your valuable input. I think Kanchan has made things quite easy now because he has talked a lot about the graft options and how exactly to choose the graft options. My presentation essentially is why I do a hamstring graft and why it is a graft of my choice over a period of time. I think I always started with the BTB when I started my practice, and but suddenly over a period of time, I actually started to shift from BTB to hamstring in almost all of my cases, except few cases where already Kanchanda has already told in his presentation. I shifted because there were issues with BTB graft. These issues were both technical issues and patient issues. Hamstring because was also a gold standard and is strongly becoming gold standard, and these were the reasons that we actually shifted to hamstring graft. And then there are certain specific things which you can do with only soft tissue grafts and not with BTB. Again, these indications will be talked in this presentation. So as I told you, till 2003, I was always using BTB. It's a single long incision where I used to harvest plugs and a graft. But then certain issues which started coming during the surgery and when hamstring started becoming popular, and these issues changed my mind from BTB in most of my patients to a hamstring graft. Length and width and the dimensions of the graft was the first problem which I started encountering in some of the patients where we were choosing to do a BTB graft. We had small, thin patients where the limited middle third of the graft harvest yielded a very thin graft, which we were quite not happy with the graft quality. We had to do a lot of calculations while doing operations. These calculations were very minimal while doing hamstring graft, and thus hamstring becomes more surgeon friendly. There were cases where the graft would be a bit longer and the plug would be hanging out if the calculations go a bit wrong. And there were cases where the graft was a bit shorter also where the plug would be jutting inside the joint. So different patients, different anatomy, so graft had issues. Most of the patients which we encounter often have a bit of chondromalacia of the patella, and these patellar surface irregularities and patellar tendinitis are relative contraindications of doing a patellar tendon autograft, and these were the reasons that anterior knee pain became quite more prominent in some group of patients after surgery, probably attributing to increase in chondromalacia patelli or patellar tendinitis. Also, it was important for us to understand that there were patients where the patella was a low-lying patella, and you actually end up making these knees much more painful and stiff after harvesting a patellar graft. And then adolescent, where probably you have bone plugs crossing the epiphyseal line, which is not a good idea. So again, these reasons were one which were discouraging us for using a bone patellar tendon bone graft. Though we never encountered any patellar fracture, but these have been reported, and again, one of the reasons why hamstring graft is much better, much more surgeon friendly. Because of our technique of a single incision right in the front, patients often had tender scar and had pain during kneeling, and some of these patients would end up with a fixed flexion deformity, which was quite crippling, and we had to really work hard on rehab to avoid this fixed flexion deformity. So all of these technical reasons and patient reasons started us to shift to a hamstring graft. We initially started with quadruple semitendinosus graft, but suddenly realized that Indian patients, the collagen from a single hamstring graft probably might be insufficient, and then there would be need to add on a gracilis graft as well. Initially, we started to see that the anterior knee pain was nearly gone. Most of these patients, even if we were not quite active doing a post-operative rehabilitation, hardly have had an FFD. Most of these patients, the patellar issues, especially patellar anterior knee pain and chondromalacia patellae, was not aggravated after the surgery, and these advantages reassured us that the hamstring graft is here to stay. Then literature started coming comparing the stiffness of hamstring ACL reconstruction with BTB, and again, both the stiffness and the maximum load capacity were comparable. And these again are good biomechanical studies, which encouraged us to increase the portfolio of doing hamstring graft, even in a higher end individuals and high level athletes as well. So as I told you, we started with a quadruple semitendinosus, but again, added gracilis in patients where the collagen tissue harvest was much less. This gave us modularity. Initially, everybody used to do a 4-tailed hamstring, but then we started to do sometimes 6-tailed and 8-tailed, depending upon the size of the footprint. We started realizing that every patient needs customization. The height, the size of the knee, and the size of the footprint of different individuals are different. And you need to fill the collagen in the footprint as much as possible. And now, in most of my cases with hamstring ACL, I'm actually doing either a 6-tailed or even sometime an 8-tailed hamstring ACL reconstruction, which is giving a good collagen fill up of the footprints and thus probably giving much more superior stability in these patients. So as I said, footprint evaluation has become much more important in my practice now, and we have to customize the graft by either a 4-tailed, 6-tailed or 8-tailed, depending upon the size and the dimension of the footprint. And that is why footprint evaluation has become a very important step after doing an arthroscopy of choosing the graft which I want to put. Also, there are some things which we can do only with soft tissue grafts and not with the bone patellar tendon bone graft. And as we do more and more arthroscopic ACL surgeries, we started to realize this. We started to see that a lot of the patients had partial ACL injuries. Either an AM bundle was isolated torn, the PL was intact. And in such patients, it was always a good idea just to do an augmentation of the ACL by putting an AM bundle. Again, there were patients where there was an isolated PL tear, and all you need to do is just put an isolated PL graft. Thus, augmentation of ACL was become much more important. Footprint restoration becomes much more important. Preserving the collagen which is still there becomes much more important. and probably soft tissue grafts are much more superior in getting this modular ACL reconstruction done. And that has become a part of our practice now in most of our cases. Also, we started to realize that a lot of patients now come to us early for the surgery, and we still have good stump of ACL which is there. So in the patients which need an ACL repair, we have started to doing ACL repair along with double-stranded ACL hamstring augmentation. So again, these kind of surgeries where you tend up repairing the ACL back to its original footprint and adding a hamstring augment helps in getting the biology much better. Again, soft tissue graft, hamstring graft comes as an important graft whenever we are dealing with such ACL fresh injuries. And then in high level athletes, probably taller individuals which have got a large pivoting phenomenon which is happening in the knee, if we don't think they need to do an extra articular procedure, we actually end up doing a double bundle ACL reconstruction. We would do an AM and an AL, PL bundle augmentation or reconstruction in such patients. And this adds on to the collagen tissue, gives more stability in different range of movement of the knee and helps us in providing much more stable knee in different degrees of flexion of the knee. So again, double bundle ACL reconstruction is something which is possible only with a soft tissue graft or the hamstring graft. And that is another reason for us to encourage hamstring graft in almost all of our patients now. And then the new kid on the block, an all inside ACL reconstruction. It has got a marketing advantage for those surgeons who are actually struggling in the practice, want to increase their practice. Obviously, they want to sell something new, and all inside ACL reconstruction is a good option. It's a technically viable option. It has got now good short-term results, and people like getting an all inside ACL reconstruction. And hamstring reconstruction graft is an ideal graft for an all inside ACL reconstruction. And again, because we do a lot of hamstring ACL reconstruction, all inside also is a good surgical tool in our hand in our arthroscopic ACL surgeries. We have often started seeing not a lot of school going kids with ACL injuries. Traditionally, all these surgeries were physical sparing and they were giving good promising results. But then there are patients which are close to the skeletal maturity now, and you actually choose to do a hamstring ACL rather than a BTBL graft in such cases because you are able to not damage the epiphyseal plates when you do a transphyseal kind of ACL reconstruction in close to skeletally mature adolescents. There are issues, as Dr. Kanchan already pointed out, about incorporation and stretch out and maybe late failures of hamstring grafts. So that is the reason we are a bit more cautious of using a hamstring graft in contact sports. Though we are lucky that in Indian patients, especially the cases which we see in our practice, we don't have skiers which come to us for any kind of surgery. We hardly have done any skiing injuries. We have very less college going athletes which come to our surgery. Most of our patients are actually usually the normal individuals who have roadside accidents, getting an ACL injury, a scooty fall or a bike fall. And that is the reason out of 99% of our cases are actually not high level athlete contact sports. So that is another reason if you talk about numbers, our numbers of hamstring ACL reconstruction are close to 99% of our practice because we hardly see high-end elite athletes in our practice, and they actually amount only 1% of our practice. So that is the reason our hamstring actually is the most common graft, and we are quite satisfied with this graft. So to conclude, we have realized over in last 20 years of using an ACL hamstring graft that it is definitely a versatile and a strong graft. It is a surgeon and a patient-friendly graft. And the new things which are coming, especially the graft modularity, ACL repair, partial ACL reconstruction, double bundle ACL reconstruction, all inside ACL reconstruction. A lot of new things which have come up in our understanding of an ACL surgery. This graft has definitely become a graft of my choice now. Thank you very much. Yeah.
So this is open to questions now. Any questions?
IPS.
Yes, Dr. Nishit.
Yeah. You said the double bundle ACL
Yes.
or extra-articular augmentation, right?
So
So how will you choose that
yeah.
this patient needs a double bundle?
So for me, there are three criteria of doing a double bundle ACL reconstruction. I usually do a double bundle ACL reconstruction if my patients are 6 feet and above. So usually they have large footprints both on the femur and the tibia. Number one. Number two, they are having a big pivot shift. So that's another indication of a double bundle ACL reconstruction. And number three is if they are into a pivoting sports. Yes, in certain subgroup of patients where I would actually do an LET instead of a double bundle ACL reconstruction are those where either they have an hyperextension, these knees have hyperextension, rather than doing a double bundle ACL reconstruction, I would do a conventional ACL reconstruction, but would add on an LET in such cases. So you have to mix and match and choose the patients depending upon their primary knee condition, their sporting activities, and the amount of pivot shift which they are presenting to us.
Any patient where you have done a double bundle and then you had to add the LET?
Yes, definitely. We had to do double bundle, add on LET. We use LET, we use the ITB for LET, iliotibial band. So that's never a problem. Something like a Lemaire's procedure. So
yeah.
There are cases that are hyperextendable. These are Kho-Kho or Kabaddi players, especially the female Kabaddi players, which are hyperextendable. They are tall girls, which come from northern part of the country, especially Punjab and Haryana. They are hyper flexible, they are lax, they pivot badly. So we end up doing double bundle ACL reconstruction and add on an LET with Lemaire's procedure in such cases. So there are indications. You're right, absolutely.
Altaf, you have a question?
Yes, sir. Yes. Do you have any issues with sometime like anomalous insertions of these hamstrings?
Yeah,
any
that's
difficulties?
That's quite common.
Because
and I think probably, if somebody says harvesting a hamstring is easier than BTB, probably that's wrong.
That's what I'm saying, because I couple of times had a lot of difficulty because this was such an anomalous.
Always in front of you, you can make the incision big or large. You can judge everything and do it. Hamstring misleads you badly. You have to really have a good experience, and each one of us, including seniors like Dr. Kanchan and Dr. Nishit, would have seen aberrant origins of hamstring in their large number of series. They would have to search hamstrings either down or up, and sometimes aberrant bands going on. And really, harvesting a good hamstring is itself an art. Agreed with you.
Once I ended up abandoning because I didn't find one.
Absolutely. Sometimes it is so low that you actually make your incision much. And I think Kanchanda would agree, and Nishit Bhai, who has got large, long experience, much more than ours, would agree to that.
Yes, absolutely.
Good. Yes, Rajiv.
Yeah. IPS, sometime in female patient, we have very thin hamstring tendons. So do you augment in those cases with some synthetic tape?
I actually not augment ACL anywhere. I think as Kanchanda actually pointed out, synthetic grafts, synthetic augments probably are not at all a good idea as intra-articular. They work extra-articularly very well. You can do MCL augmentation with internal braces, but ACL is something which is not to be done, except for an ACL repair where you probably want to protect the repair. So for primary ACL reconstruction, even if the graft is thin, I would actually not put an internal brace. I would rather change my technique by either doing modularity by 6-tail or 8-tail, or do an all inside where I need a smaller graft. Probably just putting a
internal brace
instead, it doesn't work.
So internal brace, everybody of us, I don't think that we like to use the internal brace. I think it's I do not understand a 1.5 millimeter tape or a 2 millimeter tape, how much it is going to give additional support in these patients. I do not understand. And I have done a lot of now femoral avulsions, soft tissue avulsions, and I feel that I would always go for a gracilis augmentation rather than doing internal brace. Gracilis works very well, and anything live, I think it is. it's better for us, at least, because our patients have only one surgery. Most 90% have only one surgery in the lifetime.
So
To
IPS,
convince them for revision surgery takes a lot of efforts.
you brought up something IPS which is very pertinent. Female kho and kabaddi players, as opposed to your
Yes.
practice, mine and Debash's practice in this part of the country. This is sporting, the poor city, poor state, but a sporting state. So more than half our population are athletes. They are not high-end athletes. They do not represent the country, but their livelihood depends on their athleticism. They will get a job because of that. And the vast majority of my patients are between 18 and 22. And
Hmm.
as opposed to what I just mentioned, that for high-end athletes and female athletes, I use BTB, I've also found out that women athletes have very robust hamstrings. The
Yes.
largest hamstrings I've found is an 11 millimeter from a physician's wife who had represented our state in shot put once upon a time. This was a 12 millimeter four strand CMT. This was about 20 years ago. It's the largest hamstring I've ever found. And women athletes, by and large, have very robust uh, tendons, and they may not be very long, but they're very, very stout, very, very strong. And about the LET, I think we are relearning them. This is addressing the forgotten corners which we learned 30 years ago, relearning them again.
Yeah.
So I think this was very good IPS. So I think, can we go forward with Sundar about his tips and trips on ECL, on revision ACL?
Okay. Good evening, Shivashankar sirs and Naveen sir, for giving opportunity for us to be presented with IOA. I think this is the first of kind meeting of subspecialty along with the Indian Orthopedic Association, and I congratulate the team of IOA for initiating this kind of subcommittee meetings. So my topic is on the revision ACL reconstruction tips and trips. And I will start with this case of 35 years old male patient presented with the giving way of the right knee for 1 year. For this patient underwent ACL reconstruction 5 years before following a basketball injury. And he was all right for 4 years, was playing. Again, had another injury a year ago and developed pain and swelling and instability. That was the Lachman's for him. I think that is you can see the Lachman's positive, and MRI showed a re-tear of the ACL. So unlike the primary ACL reconstruction, we should understand that revision ACL is not a simple solution where you can directly go and fix the graft. So you need to do a lot of further workup. So first we have to find out why did it fail, and it is a patient really requires a revision ACL reconstruction. Another important whether the patient is an athlete or a non-athletic patients, where just you can do a rehabilitation and wait and watch. Or some people where I had seen, even though MRI shows the re-tear of the ACL, they may not have a rotatory instability like what you see in a real ACL instability. These patients will have such just buckling of the knee because of inadequate rehabilitation of the quadriceps in the first time ACL reconstruction. So what is the ideal indications for the revision? If the patient presents with the instability, I think that is an ideal indications. We have directly can go ahead and do the ACL reconstruction without any comorbidity if the patient doesn't have any comorbidity. If the patient presents with only pain, but MRI shows re-tear of the ACL, then you have to be very, very careful. That these patients, if we do an only ACL reconstruction, then they may have an unsatisfactory outcome. So it is important whenever patient presents with the pain, make sure that you are ruling out the infection on this case. Make sure that patient doesn't have any arthritis because of the contral damages or any meniscus damages, or the patient doesn't have any stiffness. So these are the reasons for the pain. So these patients, even they have a re-tear, you should not go to a ACL. You should address the problem of the pain. If the patient has got both pain and instability, then you do a revision ACL reconstruction. Along with you address the reason for the pain, like if you have a contral or a meniscal damage, you should address that, along with any comorbidity of collateral ligaments where you may need to do a reconstruction along with the revision ACL reconstruction. So we know that initially we thought all the ACL reconstruction failed because of just trauma, because of the technique issues. But we know that the papers have shown, that Mars group have shown that is just combination of the factor, just not one factor. It could be a technical combination of the technical, and also a patient may have a trauma, and also there could be a biological incorporation problem. So these are These are the common issues when you have a revision, when you have a ACL failure. So you have to address all these issues when you do a revision ACL reconstruction. So it is important to have a clear clinical examination, make the patient to walk, to find out whether the patient has got any varus deformity. That is most important. And also to look for the range of motion to rule out any stiffness of this case because of the primary ACL reconstruction. And also examine for any patients have been missed for the collateral ligament injury, whether it's a PCL or posterior cruciate ligament or a medial or lateral collateral ligament injuries by doing the proper examination of all the ligaments tests. And when you do a plan of management, when you want to do a revision ACL, we should understand that even if you do a revision ACL, the re-revision rates are up to 88% if we do a revision ACL reconstruction. So that has to be explained to the patient that, again, this is a failure, even if you do take all the precautions when you do a revision ACL reconstruction. The another next question comes, if you decided to do a revision ACL, to do a single stage or two stage. So for that, it is important that you should have a radiological investigations. Even the plain X-rays of AP and lateral of the new knee will give you the whether position of your metallic hardware in the primary ACL reconstruction, and also the position of the pre-existing tunnels, tunnel widening and bone loss can give an idea. But still, another important X-rays to be taken is the alignment X-ray to rule out the varus deformity. So the varus deformity could be due to middle compartmental osteoarthritis because of the long-standing issue of ACL with other comorbidities, or patient who might have been missed the PLC insufficiency, so that patients might have developed varus deformity. Of course, CT scan is a must when you do a revision ACL reconstruction because that gives the exact position of the primary ACL reconstruction tunnel positioning, and also it gives the widening of the tunnel. So that is the most important, one of the most important factor when you want to do when you decide to do a single stage or a two stage procedure. So when you come to the 3D CD classification, all of us know there are three type of position of the tunnels where you can, in the femur, where you can decide about to do a single stage or two stage. Type 1 is a well-positioned tunnels. So we can do a single stage or two stage. I will come back again for this. When you have a type 2, where you have a slightly mal-positioned tunnels, where convergence between the old and new tunnels can happen. So basically, if you are starting a new, if you are new to the revision ACL, better do in a two-stage procedures. But still you can do make a divergent tunnels in sometimes, still can be done in a single stage if you are an experienced surgeon. Type 3 is the significantly mal-positioned tunnel, which we see very commonly with anterior position tunnels like this. So in these cases, definitely we can do a directly single stage revisions where we have a non-anatomical tunnel, or the patient undergone a high transtibial technique long ago, then still it's possible you can make a single stage ACL reconstruction, making in a more anatomical tunnel over here instead of the transtibial tunnel. And also these patients should have a good bone stock, and also the hardware that can be removed or should not interfere the reconstruction when you want to do a single stage. So if you have these kind of criteria, I think they are simple to do on a single stage revision ACL reconstruction. So this is one of the case where you can see the malposition tunnel. We can see that is the anterior notch. We see that malposition tunnel very, very anterior, where the tunnel is supposed to be here. And we can see that below video shows that where the anatomical tunnel is, where we made in a single stage, totally avoiding the non-anatomical tunnel. Sometimes we'll be able to do even the well-positioned femoral tunnel. We can make it a single stage if this tunnel positioning is not below 15. If the 12 to 14 are ideal, still if you have a good revision graft where you have a 12, 11 or 12 diameter, still you should be able to do a single stage where in the femoral side. So where you make a serial dilatation, start with 8 mm reamer, I slowly go with the 9, 10 and up to 11. Use the curette to remove all the soft tissues, then go to the next reamer, go to the next size. Then you can use at the end, you can use even use the all to make multiple holes to make a more biology, and these patients can be done. Or sometimes you can use a flexible reamer in the well-positioned tunnels, and especially if it is in a slightly mal-position, you can use a flexible reamers to do a single-stage reconstruction. The most often the problem comes on the tibial side, where it's very difficult to make a separate tunnel in the tibial side. Of course, you can make it the lateral side, but it's very, very difficult. So most often if you make the graft too anterior like this, when the patients can come with the graft impingement, and the loss of extension. Or the patient when you want to manage the tibial side, there are many options where we can make a single stage tibial side revision ACL reconstruction. Still, you can do a re-drilling of the tunnel in optimal position, or you make a two divergent tunnels. Even you make a two divergent tunnels, sometimes it can come and make in a single entry in the tibial side. But still, 70 to 80% you'll be able to get a good new tunnel. That should be enough for your new graft. Or you can use an allograft. If you have a facility for an allograft, you can use a big size allograft like 12 or 30. And also sometimes you can use a bias screw as a filler. We can use a bigger size screws, or you can use even stacked interference screws for the filler. Of course, lateral entry, usually I don't do the lateral entry. I was not happy for the entry point. Usually it comes very lateral, so I don't use the lateral entry. So this is one of the case where you done a tibial side entry. You can see that most often you will come into the same entry, because tibial side, the footprint, you cannot make a different entry point. The femur is a side just such a 17 mm, 15 mm wide notch. It is easy to make a divergent tunnels, but in making a tibial side, always it comes with the and ending in the same spot. So you can make a serial reaming with 9, 10, and when I use a PTB graft, I can take a 12 size graft. Most often our revisions are PTB grafts. So you should be able to get 11 or 12 size grafts. So make a good bleeding canceller surface and use a micro awl to make a multiple puncture to make more biology. Then you do a PTB incision. So I usually will get a 11 or 12. So I use usually 11 in the femur. Most often you will be able to manage with a single stage when you do a revision PTB ACL reconstruction. Should I need to remove the hardware always? That is the question which you have in mind when you do a revision ACL reconstruction. When there is a loose hardware on the way, you can remove it. Or if the tunnels are only partially malpositioned, or if it is in a correct position and the fixation devices has to be removed, or if there's especially if the screws are in the femur, it can be removed. If you are creating a totally new tunnel like in a non-anatomical tunnels in the primary ACL, you can just leave it. You don't need to touch that primary fixation screws or the buttons. So when do you want to do a stage revision? So most often when the tunnel widening is more than 15 mm, of course, when there is a malalignment, you do an osteotomy for the varus deformity. You come back and do a revision ACL. Of course, when there is an arthrofibrosis, the primary aim is to get back the movements for the patient first. Then these patients will not have instability. The later on the patient develop instability, then you can go for a revision ACL reconstruction. Of course, infection, you always do in two-stage procedures. So when you do a grafting, what kind of graft you use the filling when you want to do a staged procedure? Always better to use a bone plugs with multiple harvest plugs may be necessary if there is a substantial bony defect. And autografts can be harvested from the iliocrest, or you can use an allograft. But when you don't use the cancellous chips, usually that will get absorbed. And later on, when you do on a CT after 3 months or 6 months, usually partial healing will be there, but still some of the tunnel may not fill with the cancellous bones. So you do a CT scan after 3 to 6 months of the bone filling, after confirm the incorporation, then come back and do the second stage ACL reconstruction. What graft to use? Of course, this is one of the JBJ studies in 2017 had shown that definitely autografts are better than the allografts in relation to the post-op laxity, complications rates, and also the reoperation rates. So I'm not going in very much detail on that. So what kind of fixations? In the absence of significant tunnel expansion and good bone stock, still interference screw fixation is a good option. If the bone stock is compromised and the quality of interference fixation is modest, then it should be augmented with a suspensory device, screw post, or a ligament button, so you can do a hybrid fixation. So rehabilitation has to be slow coming to the when you compare the primary ACL reconstruction, because you are compromising the size of the graft and also the fixation. So it can be slow, especially if you are using a soft tissue graft with the suspensory fixations, requires more and longer post-operative rehabilitation, and the minimum 9 months return to sports. And also we also know that when you do a revision ACL, the success to return to sports is only around 50%. Whether I to do one revision, when you do a revision, should I add a AL tenodesis or a reconstruction? This is a study which has shown where compared the 20 patients with only ACL reconstruction, another with ITB, where they had shown that anterior tibial translation and the internal rotation reduction in group 2 than in group 1. However, there is no difference in the attachment of pre-injury activity levels in both the groups. So the take-home message is that all the ACL failures do not need revisional ACL reconstruction. So you have to make sure that this patient has got a real instability and he wants to go back to the sports. So differentiate the pain and instability, which is the most important clinical exam questions to be asked and examinations to be done to rule out the causes for pain. Your pre-op planning include the radiological investigations like a CT scan that will decide whether to do on a single stage and also whether to do a two-stage procedure. Make sure that we do a slow rehabilitation in the revisional ACL reconstruction, and it is important to treat associated injuries and structures and also the malalignment if there is, do it in a two-stage procedures after doing osteotomy. Thank you very much.
Wonderfully done, Sundar. So now, any questions? Well, Rishit is thinking, let me ask a couple of questions.
Yes, Kanchan, I wanted to ask you, Miss, if nobody wants to ask him for specifically for the revision.
Wait, let me ask Sundar for a revision, then you can ask me.
Yes.
Sundar, two questions. For the tibial fixation revision, do you always use an augmental fixation or never? And second, for one stage femoral revision, do you ever use an outside in tunneling so that you make the tunnel divergent?
Sir, luckily none of my cases I need to do an outside in technique because most of my revision ACL are due to failure of hamstring graft on the first such situations. And most of the time, as I showed in that even the presentations, even to the well-positioned tunnels, if the graft, if I can get tunnel size of less than 14 mm, still I can go, I will go and do a primary revision ACL reconstruction using the PTB graft, because most often I should be able to get a 11 size or a 12 size graft with interference screw fixation on that. It should be very good, strong fixation. So I never got the chance to use an outside in technique because of these issues. And also two or three cases of failure of PTBs, I had used the allograft because we have the facility to do as an allograft. I had used a quadriceps revision in that cases where you get a big size graft of around 12 size. And also I had used tendoachilles allografts.
And for the tibia, do you ever use a
No, sir. Tibial side also I have not used most because the PTB graft most often fills. If I know that it is well positioned tunnel, always I make a divergent tunnel. I tried a lateral side entry. I was never happy in my previous 4 or 5 years before. I never try a lateral side, but always I have a chance of making another divergent tunnel in the tibial side very easy from the medial side because you have a big medial surface.
Yeah, and you make it more vertical anyway.
Yes, sir. So
you make it more vertical, so you got a longer graft for your BTB anyway.
Even it's divergent at the end, still you'll be able to make 70%, 80% of the fresh tunnel.
True. Perfect. Yes, Nishit, you were saying something? Unmute yourself.
You have been doing also a bone patella bone full incision.
Yes.
Okay. And as we know that for revision is a very good graft. For primary, let us forget about primary, but so what problems you have seen in those patients who you have done with a full incision?
Not really.
Bone. Huh?
Not really. I mean, over all those years, I've rarely come across any patient who's come complaining about anterior knee pain or kneeling pain. I've rarely come across anyone.
What? So see, that is my experience also. Then why? What is the reason? What do you think?
We've already heard about it, but then in my practice, very few of them really come cribbing or moaning about this pain.
Sundar, you must have used few of them in revision, right?
Yes, sir. So actually, even I was doing the PTB graft for almost 7-8 years, from 2005 to almost 2010, before we change into the hamstring. I think all of us might have used a PTB graft in and out. And even my incision is around 3 to 4 centimeter only, and I make a slightly medial curved incision. So I
Right.
don't go in the central incision, so where the people complains that when I kneel, I have a scar pain. So I make a slightly curved incision. And
Right.
another important advantage in the PTB harvest is when you do an extension, your skin can retract around 2 centimeter. You can just retract the skin for the
Absolutely.
harvest. When you do a 90-degree flexion, you have a tibial side retract. So I do hardly 3 to 4 centimeter incision. So even I never do a 2 incision technique. So I never changed my technique for the last 15 years.
Yeah, I understand. Basically, so that is what I'm saying, that why we are talking so much about anterior knee pain when we do what patient doesn't. It's okay. It's okay. And have you found problems in adjusting the length of the bone patella bone graft?
Not me. But having said that, for all my BTB surgery, I use a jig, which is an Arthrex jig, which by default makes my tibial tunnel quite long. I can easily get a 45, 50 millimeter tibial tunnel. The vast majority of my BTB graft is anything between 85 and 100 millimeters. Sometimes if I get 105 millimeters, it's a bit of a problem, but up to 105 is 100 is fine. Very rarely do I get a small bit sticking out. Very rarely.
Right. Okay. And what is your fixation on tibia?
Interference.
Okay. Both. Either bio or metal.
I still prefer metal. I'll tell you one thing. I've had great grief with interference tool fixation on the right side because of it walking. And in my early part of my career, after we came from doing outside into 6.5 millimeter cancellous screws, you and I both use.
Yeah.
I did about 100 of them with femoral press fit, mind you. Very good results. But
Yeah. I have seen it.
Yes, so with great results. But those days we did not allow them knee flexion for about 3 or 4 weeks.
Yeah.
And right now, well, for the last many years, for the right knee, I always use a reverse thread screw.
Why?
It doesn't walk. It doesn't walk. I've had a few of them walking, and it makes me uncomfortable. So the right side is the Pinchowski screw. So you do a reverse thread, and it doesn't walk.
Okay.
The only difficulty is it only comes in 725, but that's all right.
It's all right. That's all right.
Yes, Rajiv, you're saying something.
Yeah, Sundar, when do you decide that you have to graft this tunnel? Is there any criteria you follow?
Yes, most of the time my criteria is only the tunnel is more than 15 mm. So there are maybe very rarely I do a division in 2 stages. So only my criteria, if the tunnel is more than 15, then I don't take a chance. Then they come back as a second stage. I mean, other than that, you have an of course infection, or if the patient had a stiffness, I don't do a revision ACL. You do a first arthrolysis, get back the movements. If the patient had an infection, and very few patient comes back for the revision ACL reconstruction, because once you explain the chance of again getting infection. So I think most of the patients also not a very high level athlete, so they don't. I don't recommend them to do a revision ACL, because by the time they'll get some stiffness in the knee because of the infection.
It'll become fairly stable.
They will be completely stable.
Yeah. So I think we can conclude here now.
Yeah.
So I thank all of you for.
Shiv Shankar sir was there continuously hearing our talks.
And Dr. Shiv Shankar, thank you for your patience for being with us for all this time.
Thank you. Thank you.
Thank you very much for all the energy that you have shown and shown us the paths to carry on this way. This is the first time that's ever happened, like Sundar has mentioned, and I'm sure we can do this more and more often. I only commiserate with you. If you have to sit for every time for an hour and a half, that is a very heavy price for the COVID generated lack of practice. Thank you very much. Thank you all of you.
Thank you very much.
Thank you, ArthoTV.
Good evening, and we should stay safe.
It's a boon in disguise, because as we are free.
Yes, we are.
Right. Okay. See you then.
Good
Bye.
night.
Yes.
Bye-bye.
Bye-bye.
Stay safe, stay well. Good night.
Good night.
Thank you, sir.